to recognize normal brain anatomy in both the axial and sagittal planes, learn how to ultrasound the first trimester brain systematically, and then recognize the ultrasound appearances of first trimester brain anomalies. All right, so I guess what I found from scanning the fetal brain in the first trimester is that it actually requires a structured scanning approach. And a lot of the structures that we see in the fetal brain just don't jump out at us. We actually have to go looking for them, and we have to get the correct planes to be able to see those structures. So the most recent issue of guidelines on first trimester scanning, which were published in 2023, state the axial plane of the head and the brain need to be assessed. So they're the only ones that are actually recommended. But we should, and as I said, we should be assessing the brain in axial, so they're our standard planes. And if you can get them, and you need the sagittal plane for the nuchal translucency, we need to learn what a normal sagittal brain looks like. And then really extending the examination, you would include coronal images of the brain, but I'm not going to go through coronal images today because of time constraints. So that brings us on. We'll start with the first plane of the fetal brain, which of the normal axial head and brain, and this is called the suprathalamic section. Now, this section is the plane where a recent paper, so it's only just been published in 2025 in the ISUOG journal, and this is the plane that they have done some research on 49,000 fetuses, and shown that if we measure the BPD at this plane and they measured it from outer to outer on the head, on the skull, that it is as good for dating as a crown rump length. So this is the brain. This is a section of the brain I think that we all recognize because it's the most easy to see the parts of the fetal brain. So what can we see in this section? Well, we can see the cranium is forming. So this echogenic white outer circle here is the cranium of the brain. We can see some of the suture lines that are starting to form here that are, well, they've already formed, but we can see a suture line here. You can see the brain dividing with the interhemispheric fissure, which is the line running down the middle. And then anteriorly here, we can see part of the very rudimentary frontal lobe of the cortex of the brain starting to develop. And then posterior, we can just see a little bit of the occipital lobe of the cortex as well. We can see two choroid plexus, and they should be butterfly shaped. They should almost fill the lateral ventricles, which we can see is the black area in around here. And they should be fairly symmetrical in shape. And we can also see this is the cortex here. So the cortex of the brain is very thin at this stage, but we can just see the lateral fissure is just starting to develop here. So we can actually see quite a lot in this plane. If you scan inferior in the fetal brain from that suprathalamic plane, what we can see is, again, you can still see the choroid plexus, but sometimes in about 50% of normal fetuses, you'll see this little anechoic box-like structure in the center of the fetal brain. And this used to be mistakenly called the third ventricle, but it's actually the cavum velum interposti. And what that is it's a potential space between the third ventricle and the telochoroidea of the third ventricle, and it contains cerebrospinal fluid. And so basically it's just folding of the dura. It's the pia mater dura in the fetal brain in that area. So don't mistake this for the third ventricle. So but what we can see here is still we can see the interhemispheric fissure. We can see the choroid plexus. They don't quite fill the brain as much as they do when you scan a little bit more superiorly. We can actually see the walls of some of the walls of the lateral ventricles here, and then we can see a little bit more brain, cortex of the brain. Now, scanning inferiorly to that plane again, we get to the plane of the thalamus. Now, in this plane, we can again see the echogenic cranium or skull. We can see a few more suture lines here. There's the coronal suture and the lambdoid suture posteriorly. You can still see a little bit of choroid plexus there anteriorly, the interhemispheric fissure, and we can see the two thalami. So they should be separate, and one lobe of each thalami should be sitting on each side of the interhemispheric fissure. Now, this tiny little slit-like structure here, it's just that very, not quite as bright white, between the thalami is actually the third ventricle, so it's very tiny in the normal fetus. And then posterior and slightly inferior to the thalami, on either side we can see the cerebral peduncles, and between the cerebral peduncles, this is the cerebral aqueduct here. So this should be sitting at a distance from the occipital bone, which is posterior here. So this bracket is showing you that there is quite a distance between the posterior border of the cerebral aqueduct and the occipital bone here. And in fetuses that have spina bifida, this distance will often decrease. So the cerebral aqueduct will be seen much closer to the occipital bone, or it may not be seen at all. Okay. And then, so we're scanning from superior to inferior, so we're getting more and more inferior here. So this is getting this on the image on the left. This fetus is about 13 weeks in gestation. So at around 13 weeks, you'll start to see the cerebellum in the fetus. So it's a bit difficult to see, so I've actually outlined it here in orange for you. Again, we can see the interhemispheric fissure, and on just anterior to the cerebellum, we can see the two cerebral peduncles there. And then behind the cerebellum, you can see this echogenic area here. So this echogenic line that's a little bit thicker than a line. And this is the fourth ventricle choroid plexus, and it's been referred to in the literature as the choroid bar. And we can actually see that choroid bar in the sagittal view as well. And if I scan just at the back part of the brain, if I scan a little bit more caudally, and these are tiny, tiny movements that we make. So just scanning a little bit inferior to the cerebellum, you can see the fourth ventricle here in the middle, and then on either side, these little echogenic dots. And this is again picking up the choroid plexus in the area of the fourth ventricle. And this is important when we're looking for posterior fossa anomalies in the fetus in the first trimester. So in a normal brain, these are placed quite medially. You can see they're quite close together. But if you get something, and I'll show you an example later, with like a Dandy Walker malformation. These are often separated out quite laterally on either side. So it's important, I think, if you've got the ability to save a cine of the fetal brain, I think it's really important to take a cine to run through the fetal brain from superior through, oh well, here I'm going from inferior through to superior. So we're going inferior there and just finding the fetal head again, and we're starting superiorly, so out of the brain and then going through. We can see that division, we can see the thalami, we can see fetal eyes and little hands there. Now, with the fetus in this position, so we can see that it's looking straight up towards the transducer. So it's lying in a supine position, so it's on its back and it's looking up at us like that. That's a perfect position with that falx straight up and down in line with the transducer and the beam. If you turn your ultrasound transducer 90 degrees on that fetal head, you will get a sagittal view of the brain. So let's all pretend we've just turned our transducer 90 degrees. And this is what a normal sagittal brain structure looks like. So the literature talks about looking for 3 spaces. Now, I don't know about you, but I think there's an awful lot going on around here. You know, there's a lot of structures that you have to remember, that you have to see. And I had a huge amount of difficulty trying to remember what they were and in what order they are. And personally, I need to think up some sort of acronym to help me remember things like this, because it's probably my old brain, but I just can never remember these along with everything else I have to remember. So what I came up with was DBIC, so DBICC. And when I look at the fetal brain now, I say to myself, okay, DBIC, can I see those 4 structures? There's the 3 spaces that we're looking at in this posterior part of the brain, but there's actually 4 structures. So the 4 structures, and if we look on the right-hand image, the brown circle is the diencephalon, or thalami, it's called in the literature. And then the yellow structure, B, is the brain stem. Then next we see I, which is the intracranial translucency, or the 4th ventricle. Then there is the first C, which is the choroid bar. Remember, we saw that in the axial view. So the choroid bar is the 4th ventricle choroid plexus. Sorry, that's here in the green. And then posterior to that, we have the cisterna magna, which is the 2nd C. So DBICC, DBIC. And then posterior to that on the left-hand screen, so we can see diencephalon, brainstem, intracranial translucency, or 4th ventricle, the choroid bar here, which you can see it's quite thick and echogenic, cisterna magna, and then the occipital bone, and then posterior to the occipital bone is your nuchal translucency. Now, the other thing you can see in this sagittal view is we can see part of the cranium starting to form anteriorly here as well. So hopefully that makes it easier for you. I know it's helped me every time I scan. And actually the medical practitioners that report on it love it when I label them now. I label it DBICCC, and they love it. They're like, oh, I don't have to look and I don't have to think. What I learned from getting this image and seeing all these structures is it doesn't just jump out at you. You actually have to work to show these structures. and you have to get a really good sagittal view. So just because you've got a nuchal translucency doesn't mean that you will necessarily see these structures. So you actually have to do a dedicated scan to look for these structures in the fetal brain. All right, so once we've got that sagittal view of the fetal brain, we can do some measurements if we're interested in, if we think a baby's got spina bifida or some other brain abnormality, or if we just want to prove that that brain looks okay to us. So the first measurement I'll talk about is the brainstem thickness divided by the occipital bone ratio. So it's BS here over BSOB. So brainstem occipital brain ratio. So remember, it's DBI. So this is the fourth ventricle. There's the choroid bar, and then there is the see, I told you I'd forget. DBICC, cisterna magna. I've labelled it. Heaven's sakes. Anyway, so in the normal fetus, the brain stem is normally smaller than the fourth ventricle, the choroid bar, and the cisterna magna combined here. So this measurement here. And in the normal fetus, the ratio of the brainstem over the BSOB is about 0.5 to 1. So we can see here that the brainstem is about half the thickness of the combined measurement of the BSOB. When there is spina bifida, this ratio increases, and so the brainstem will look larger than the BSOB, and often you can't see the cisterna magna, and you can't see the choroid bar, or you might only just see one structure in here instead of these three. Now, the other measurement that is in the literature is drawing a line from the maxilla, so along the top of the maxilla, to the occipital bone posteriorly here at the back of the fetus. And we look at this normal structure here, which is this midbrain brainstem structure. So you can see that's a little peak here, okay? And that little dent or little peak, that junction should be above this orange line. So when you get spina bifida, you get tethering of the brain structures, and the cerebellum gets pulled down into the area of the cisterna magna. And so you lose, that's why you get that banana-shaped cerebellum later on in pregnancy, but you also lose the cisterna magna area here, and sometimes you lose that, you can't see the choroid plexus as well. I hope that makes sense. So we'll go through these measurements again with some examples of abnormal fetal brains. And then just finally, if you're looking at the fetal brain, and say a lady comes back and she's had a history of agenesis of the corpus callosum, or you have a particular reason why you want to try and say there's likely a corpus callosum in the first trimester, you can look for the pericallosal artery. So this is also imaged in the sagittal section, and seeing the pericallosal artery is an indirect sign of corpus callosal development. So this is the anterior cerebral artery here, and we can see this little blue vessel here, the semicircular vessel that runs posterior and inferior is the pericallosal artery. And look at this, even on this view, we can see D, B, I, C, C. So that brain looks normal as well. All right. Now, when we're assessing the fetal brain, it's really important as well to assess the face, because sometimes brain anomalies are associated with facial anomalies. And once I had a fetus that had quite major facial anomalies, and the brain looked quite normal. And it wasn't until autopsy that they actually found that the facial anomalies were probably caused by a very small anterior encephalocele, which we couldn't see on ultrasound. So I think, and then we're looking for clefts, and there is a relationship between midline facial anomalies and hollow prosencephaly. So important to look at the face. So in this coronal plane, we can see two eyes here. We can see the retronasal triangle as it's been described, and the bottom of the triangle here is the palate. In this coronal view, so fetus is lying on its side, we can see again the interhemispheric fissure in the anterior part of the brain. We can see two lenses within the orbits, and the orbits appear to be, normally spaced. They're not too close, they're not too far away. And we can see a little chin here. And then again, in that sagittal view, we can see a normal looking forehead. You can see a nose. We can see the nasal bone. So the nasal bone is this section here. So we should see two lines. So it looks like an equal sign from a maths equation. And then you get the third little dot, and that's the tip of the nose, the skin of the nose. And we can see a maxilla here, and then the hard palate in here, and then a normal looking mandible and chin. So we can get a lot of information from these views. And then finally, when we're looking at the brain, we should also have a look at the spine. So this is just showing you a still photo of the fetal spine, a little bit hard. This looks a little bit irregular in a couple of places. So I think, again, it's always handy to take a cine if you've got that capability, just to show. We can see the spine in its entirety here. We can see sort of the sacral area of the spine starting to form a little ductile. You can pick it up, and then an intact skin line. Now, I know when you scan and you're measuring the nuchal translucency, the ultrasound settings have quite high contrast resolution. They're very black and white. And sometimes you might consider changing from that nuchal setting to a setting that has less contrast in it. So that might be just a basic first trimester scan, or it might even be swapping over to the second trimester settings on your ultrasound machine just to get a good look at the skin. All right, so I think that's the end of normal for us. So we'll move on to assessing first trimester cranium and brain anomalies. So I hope you're all with me here. It's a lot to take in. So throughout all 3 trimesters of pregnancy, thanks for the thumbs up, throughout all 3 trimesters of pregnancy, there's 4 things that we can look at. In the first trimester, there's only really 3 things that we can assess out of this list. So we will never be able to detect microcephaly in the first trimester, so we won't talk about size anymore. But what we're really interested in is the integrity of the skull. So if it's absent, you can get acrania, or if there's is there a defect in the skull with brain protrusion, that's an encephalocele. We can look at the shape. And in this case, we're only really going to see abnormal shaped head with lethal skeletal dysplasias, so the cloverleaf shape or trigoncephaly. And when you see those abnormal shaped heads, if it's a lethal skeletal dysplasia, you'll see very short, long bones, and you'll see a very small chest, and the fetal abdomen will abdomen will appear to be quite huge in relation to the chest because the chest is so small. And then with holoprosencephaly, with shape, you'll get a very round head. And sometimes I've found with very new ultrasound practitioners, when they first start scanning the first trimester fetus, they don't recognize the holoprosencephaly, but they notice that this head is round like a soccer ball rather than a rugby ball, rather than that egg-shaped. And then density is important. So if the skull's not echogenic and you can easily compress it with the ultrasound probe, then you have to be thinking about osteogenesis imperfecta or hypophosphatasia. And again, they will usually have abnormal looking limbs. Right, so we'll move through that list now. So we're going through all those different sections. So acrania is absence of the cranial vault. And why this is a problem is because it exposes the fetal brain to the amniotic fluid, and that leads to destruction of the brain. So by about the second trimester, if this hasn't been detected in the first trimester and the person's having their first scan in the second trimester or maybe even in the third trimester, you will find that there's anencephaly, so that there's no skull and there's no brain tissue at all. So, look, there have been different subtypes reported. I don't think they're really important apart from the fact that it shows you that the brain can, in the first trimester, can have different appearances when there is acrania. So you might see a cystic structure in the fetal brain, which you can see in the top picture here. You might have a fetal brain that is overhanging the face, so we can see a little bit of overhang in this bottom video. And then you can have lobular and foreshortened brain. So here we can see the fetal brain's not enclosed in the cranium, and so that it's lobular and it's floating around within the amniotic fluid. Now, with acrania, we really should have 100% detection rate by 11 weeks when the scan is performed by experienced practitioners. Now, this ultrasound was performed in an early pregnancy unit, and the person doing this scan was not used to looking at the anatomy of the fetus per se. And while they didn't know what this was, they recognized that this wasn't a normal appearance. And so they referred this patient to the unit where I work, to the perinatal ultrasound unit. The other issue with integrity is, as I said, looking for an encephalocele. So an encephalocele is a protrusion of the brain or the meninges through a cranial defect. So that cranial defect is normally in the area of where you'd see the fontanelle or where you'd see a suture. Having said that, most encephaloceles are located in the occipital region, which we can see with this fetus here in this fetal brain. So about 3/4 of them, and we can see a little bit of brain tissue in that. And about 2/3 of encephalocele in the fetus will contain brain tissue. And about 2/3 of them as well will present as an isolated anomaly in the first trimester. Now, they have been reported to increase in size and change in content with increasing gestation. So while in dedicated units, they have reported 100% detection rate of encephaloceles, and that might just indicate that they have not scanned enough encephaloceles if they are not missing, if they've never missed one. When we look at just first trimester screening and ultrasound in general, where anatomical screening is not specifically included in that examination, the detection rate, and this is a recent paper from 23, has only been reported as 8%. The other thing that's important if you detect an encephalocele is to have a look at the fetal hands. So we're looking, and feet, we're looking for axial polydactyly, and also look at the fetal kidneys to see if there is any evidence of polycystic kidneys, because the fetus might have autosomal recessive disorder, Meckel-Gruber syndrome, and encephaloceles have also been reported with body stalk anomaly and amniotic band syndrome, and as I said before, with associated facial anomalies. So we've got a few more examples here. So on the left, we can see this is a first trimester scan, and you can see that this looks like it was quite a difficult ultrasound. You know, the resolution is not great, and this fetus is about 12 weeks of age. And I'm hoping that you can appreciate, even though it is a poor ultrasound image, that the intracranial structures, so the three spaces or the DBIC, are difficult to see. So what we can see here is the diencephalon and the brain stem, and then we've got the occipital bone. So we're missing the fourth ventricle here and the choroid plexus bar and the cisterna magna, and then there's the nuchal measurement. Now, this, and we can see here in this area here, it's difficult to see the occipital bone, but it looks okay, it looks intact. Now, this fetus had an encephalocele, and this is the same fetus in the second trimester where the diagnosis was made, and it was missed in the first trimester. So there could be a number of reasons for that. It could be that the imaging was difficult, and possibly transvaginal ultrasound would improve visualization. I think it also shows us that we should be looking at the fetal head and brain in more than one plane, because I believe that only a sagittal view was taken of this fetus. But it also makes you question, you know, things like encephalocele can increase in size, and maybe it wasn't visible in the first trimester in this case. Here's another example. This is another first trimester fetus that had an encephalocele, which was diagnosed later in gestation, and this one was again not detected in the first trimester. So we can see this is much nicer quality here. We can see a nasal bone. You can see the maxilla here. We can see, but if we look carefully at the fetal brain, we can see the diencephalon, the brain stem, and the intracranial translucency. But the choroid plexus bar and the cisterna magna are quite difficult to see. Having said that, the occipital bone looks quite intact here. So that actually looks quite normal. You know, if I looked at that, I'd go, oh yeah, that occipital area looks fine. And then again, we can just see two structures in the fetal brain. We can see the choroid bar on this fetus, but very, very small to absent intracranial translucency, so fourth ventricle and cisterna magna. And again, we can see that the occipital bone looks intact. So this again was a second trimester diagnosis, and we can see that basically this encephalocele appears to have meninges in it, though you can see some of the other brain structures are starting to herniate into that defect in the skull. And here is a couple more images of the same fetal brain. So again, was this later diagnosis because the defect increases in size with increasing gestation? And while the defect would always have been there. Maybe the meninges hadn't herniated out of that defect in the first trimester. So I guess we need to make sure we're doing both axial and sagittal views, and we should be considering a transvaginal scan if we don't get really clear outline of the fetal cranium in axial and sagittal. So I haven't got any images of abnormal shaped heads because I thought about getting them too late, and so I was unable to go looking for them. So these are normal brains here, but with shape, we're looking for quite abnormal shapes in the first trimester. So the cloverleaf shape says it all. It's got the three sort of cloverleaf shapes, so 3 separate rounded structures. And this is because you're getting fusion of the sagittal, which we can't see in this axial view, the coronal, so here's a coronal suture, you get fusion here, and the lambdoid sutures here. So with a cloverleaf shape, this area here becomes narrowed and the head becomes quite tall. And then we also get narrowing of this area here. So we get a bulge and a bulge here, and then we get 2 bulges at the back. With trigoncephaly, which is another anomaly associated with lethal skeletal dysplasias, you get fusion of the metopic suture. And you can see the metopic suture really well if you take a 3D, 4D picture of the first trimester fetus of its face. And patients often think that baby's got a big chunk out of its forehead. It's that the metopic suture is that widely spaced in the first trimester. So this is an axial view here. We can just see the eyes, and this is the metopic suture here, and you can see that it's opening out into this triangle, and that triangle just gets really quite wide and joins up with the anterior fontanelle in the first trimester. Now it closes from this inferior section, so low in the forehead, it closes, and it closes more superiorly as the fetus gets older. And by about 30 to 32 weeks, the metopic suture has fused. And it's about that time that we start having trouble seeing into the fetal brain from the anterior part. And we have to go around to the and scan through the coronal suture to see parts of the fetal brain. So just be aware that other forms of craniosynostosis can't be diagnosed in the first trimester. So if you see an really abnormal shaped head, think lethal skeletal dysplasia. And then out of our list from before, we can look at density. So remember, we're checking for an echogenic cranium. And this is not like anencephaly where the brain is floating free. The brain is still held in place by a skull. It's just that it's very poorly mineralized, and it is very soft. And so if you push on that baby's head, on that fetus's head with your transducer, you'll be able to squash it down quite easily. So this is a 12-week fetus. This one has an abnormal skull density here. I think this fetus had osteogenesis imperfecta. Now, this was actually missed in the first trimester, and the people that scanned it this fetus also had short limbs, and so the couple were counselled for trisomy 18, and the woman chose to have non-invasive prenatal testing of fetal DNA from the maternal blood, and it came back at low risk. So they continued with the pregnancy, and this particular fetus was then scanned in another unit where the skeletal dysplasia was found. And So when we see these sort of appearances, and they can be quite subtle, but you can see that we can see the brain really clearly on this side that's closest to the transducer. Your differential diagnosis is osteogenesis imperfecta or hypophosphatasia. All right, so that brings us on to spina bifida. So if we're assessing the brain to diagnose open spina bifida, again, we're looking in that sagittal view to start with, and we're looking for an absent or compressed fourth ventricle, so intracranial translucency, with collapse of the cisterna magna, which is that Chiari-2 malformation where the brain gets tethered and pulled down into the brainstem area, into that cisterna magna area. So here, this fetus had spina bifida. We can see the diencephalon, and then we can see the brainstem. Look how big it looks here compared to this fourth ventricle and cisterna magna, and it's very difficult to see that choroid plexus of the fourth ventricle as well. If we put that line from across the maxilla here, so this fetus maxilla is actually really difficult to see. It makes you wonder if it's got a big cleft there. But anyway, we're running it here. That's the top lip through there to the back of the occipital bone. And here's that little junction that we talked about before. And you can see that the brain, the diencephalon or thalami, and the brainstem have been pulled quite inferiorly. So that little junction is down near that line now. And again, that brainstem, I think this is quite subtle, but the brainstem measurement is larger than the BSOB ratio here. So we can see that that ratio is increased. Now, I talked before about the importance of looking for the cerebral aqueduct. So here is this this is the thalami. We can still see thalami in this view. Got interhemispheric fissure. Here are the cerebral peduncles, but we can see we're missing that box-like shape of the cerebral aqueduct here. And this has been described as the car crash sign because somebody thought that this part of the brain, the peduncles, look like a car bonnet crashing into a wall here, which is the occipital bone. And so you either get the aqueduct or cerebral aqueduct sitting very close to the occipital bone, or in this case, it's absent. And in this retrospective study, 90% of cases of open spina bifida displayed this car crash sign. Other features in the fetal brain of spina bifida in the first trimester are what's called a dry brain appearances. So here we can see that the choroid plexus of the brain appears to almost fill the entire cranium. Okay, there's very little ventricle space left here. We can see the falx. And choroid plexus has been shown to fill the head in 88% of fetuses with spina bifida, and this is because you're getting leakage when it's an open spina bifida. You're getting leakage of the CSF fluid from the defect in the spine. So this sign has been reported to disappear around 13 weeks when the cerebellum develops. So this is the same fetus in sagittal. Again, this was a case of spina bifida that was missed in the first trimester. So we've gone back and looked at this retrospectively. And what you'll find is in nearly all the series that have been published so far, looking at these signs in sagittal, in the fetal brain, and all these other signs, they're all retrospective studies. So there are basically no prospective studies. So here we can see the diencephalon, so D, B, intracranial the brainstem, and then the eye. Here is the fourth ventricle, and then we've got a collapsed cisterna magna. Here we've got a larger brainstem compared to the BSOB measurement here. And then that little dimple part, that junction, so the brain has been pulled down into the posterior fossa area, and that junction is sitting almost on that line again. This is the same case, and this is the 19-week scan, and we have the diagnosis here of spina bifida. So we can see the banana cerebellum from the Chiari-2 malformation here. We've got absence of the cisterna magna. There's mild ventricular megaly. It measures at 11 millimeters. And this fetus had a lumbosacral meningocele between L5 and S1. Just another case. This spina bifida case was detected in the first trimester. These are beautiful images. So again, we've got a sagittal, we've got cranium forming here. We can see a nasal bone. We can see maxilla here. And then here is the diencephalon, so D, B, that's the brainstem. And again, we've only got the one eye here, and we've got no cisterna magna, okay? And then that brainstem looks larger. We can see it measured over here than the BSOB area, so just in here. We can actually see a bit of choroid, the choroid bar sitting here though. And then that line running on the maxilla, and you can see that the diencephalon or the thalami has been pulled down towards the posterior fossa in this brain, and there's that sort of junction area sitting on the line again. In this same fetus, we can see the car crash sign here. So there's absence of the cerebral aqueduct, and we can see the peduncles and the thalami being pulled down towards the occipital bone here posteriorly. And then this is an open spina bifida, so we've got leaking CSF, so the fetal skull is small, was giving us a small BPD, and again we can see the car crash sign at this level. So this it's as I said before, it was only very recently that they had done this large multi-center study stating where they were going to measure the fetal BPD. So you will still find that people will measure it at the level of the thalami, the same as we do in the second and third trimester. And some people will do it at the level of the choroid plexus. So I guess we watch this space. All right, a few more things to go. Not long now. So we'll move on to ventricular megaly. Now, the measurements that we make in the second trimester of the lateral ventricle are not valid in the first trimester. So when we're looking at the mid-sagittal brain with ventricular megaly, it's not visible in that mid-sagittal, and that's because what we're seeing is the falx cerebri. So here, this area of the interhemispheric fissure. So we're seeing the falx cerebri, which is what this is. You look at the midline of this brain, and it's quite messy, and this is because this fetus had ventricular megaly, and it was caused from ganglionic eminence cavitations, which I am not going to go into today. But this is the same brain. So this is a first trimester fetus with ventricular megaly. And what they've shown is that the ratios of the size of the ventricle to the choroid plexus is reduced in fetuses who later go on to develop ventricular megaly. So there's a number of ratios that have been reported. One is doing a diameter of the ventricle and a diameter of the choroid plexus and getting a ratio. So choroid plexus over lateral ventricle diameter, diameter area. Another one is the diameter here, the orange lines of the choroid plexus to the ventricle. And then the other one is this distance here, so the length. and that's measuring the length of the choroid plexus over the length of the brain. Now, what this does is it predicts an increased risk of ventriculomegaly. And I think what they've found is it's very difficult to say absolutely that a fetus has ventriculomegaly, and there is not enough data to give you a number or a ratio that will tell you, yes, this fetus has or hasn't got ventriculomegaly. So all it's doing is predicting an increased risk and suggesting that, and you should be suggesting that an early repeat second trimester, probably about 15 to 16 weeks, is recommended if you're suspecting that there might be ventriculomegaly. All right, so holoprosencephaly. Now, there's three types of holoprosencephaly. There's alobar, semilobar, and lobar. And realistically, the type that we're looking for in the first trimester is alobar, which is the worst type. With alobar holoprosencephaly, we've got a single ventricle, which we can see here. There's absence of the interhemispheric fissure, and the choroid plexus has no butterfly sign, and you can see that it's crossing the midline here. So, well, there's no midline, but it's crossing over between and joining up on the two sides of the brain. And if we could see, there's a thalami there, we've got a single fused thalami. So if we come back through that, that's the single ventricle. There's our fused choroid plexus. There's no interhemispheric fissure. There's a little bit of occipital lobe of the brain there. And then as we move up, we've got a single fused thalami. And I don't know if you've noticed, but this fetus also has 6 fingers on each hand. And these eyes are very tiny, and they're very small, and they look very close together. And this fetus also had an atrioventricular septal defect, and it was high risk for trisomy 18. And I thought, oh, it's going to have trisomy 18 or even 13 with a polydactyly, but it actually had trisomy 10. So remember that holoprosencephaly is associated. It doesn't always occur, but it is associated with facial anomalies. And look, detection rate has been reported as 100% in the first trimester. Having said that, if you've not seen this before, you can be fooled, and I'll just show you how that can happen. So just on the left, this is classic. This is a different fetus, but this is classic for holoprosencephaly, alobar holoprosencephaly. Again, we've got a very round head. You can see the single ventricle and the fused choroid plexus. Now, if we scan a little bit more inferiorly in the brain, you can actually see what looks like 2 separate thalami here. But if we look carefully at here, this area, we can see that there's actually a single ventricle here. And this line, there's the cerebral aqueduct here, and this line is actually the division of the base of the brain. So the cerebral peduncles and that sort of cerebellar area, okay? So it is easy to get it. Look, you can get it wrong. And this is why I said earlier, we need to scan through the entire fetal brain to have a look at the entire head and not just scan one plane. All right, this is the last sort of anomalies that we're going through now. You'll be pleased to hear. So cystic posterior fossa anomalies, also known as Dandy-Walker malformations. So in the sagittal view, we will see increased fluid in the area of the 4th ventricle. Okay, again, we've got loss of the 3 spaces. So we've got the diencephalon and the brain stem, and then we've just got this big cystic area here. And it's very difficult to see the choroid bar and there's a big cisterna magna. So we can't see the 4th ventricle and the choroid bar. So what happens in these fetuses is that the choroid plexus is displaced laterally, so we don't see it in the sagittal view. And in the axial view, we will see an enlarged fourth ventricle, and you'll see the actual lateral displacement of the choroid plexus in that view. And but in the sagittal view, you get absence of that choroid bar. So here, these are actually coronal views of the posterior fossa, and we can see again that big cystic space. And what we've got here, these two little echogenic dots here. Remember, I was talked about earlier, looking in the posterior fossa in axial, and you can also see it in coronal. And those two little echogenic dots that were on either side of the fourth ventricle, which is in this area here, were very close together, and see how widely spaced they are. And here's the axial view here, and you can see this little echogenic dot over here. This is the choroid plexus. So it is really widely spaced, and we're not getting that nice echogenic, thick, white choroid bar that we see in the normal brain. All right, I hope all that made sense. So I guess my closing remarks are, it's really important to know the ultrasound features of the normal first trimester brain anatomy, so that when you see something different, you will recognize it. A lot of these things don't jump out at you. You have to go looking for them, especially I've found with the sagittal views of the fetal brain. And that's the way we're going to increase our first trimester detection rate of fetal brain anomalies. And I would suggest imaging in more than one plane routinely to assess the brain and cranium. So axial at a minimum, and then adding sagittal. And if you can't see that fetal brain clearly and you can't see the cranium clearly, if you've got the facilities, then think about doing a vaginal scan if the woman is happy with that and you've got the tools for high-level disinfection. So these are my references here. There's lots and lots of them because there has been in recent years, and there's another page. So if anybody wants to go back and look for some of these references. And thank you everybody for listening. And I think, thanks. And I'll hand back to Luke and see if we've got any more questions. Any questions?
Right, thank you. Thank you, Anne. Fantastic. As always, great presentation.
Thank you.
Great images and videos, both of the normal appearance and also the abnormal appearance as well of the fetal brain. I'd encourage everyone. There's been a few questions that have come through. I'd encourage everyone to that does have a question. Don't be shy. Pop it in the Q&A section at the bottom of the webinar, and we'll try to get to it as quickly as we can. We've got a few questions here, and the first one is from Bonaventure, who has asked, when I'm assessing increased posterior fossa fluid, could you kindly explain in simple terms how to know when the vermis is rotated, how to know when the torcular or tentorium is elevated, and when I can know when the vermis is normal in size?
I don't know that we can do that in the first trimester because until 13 plus weeks, we have trouble seeing the cerebellum, and the cerebellum is bigger than the vermis. So I think looking at rotation of the vermis is a first trimester, is probably a second trimester diagnosis. Let me have a look. So looking for elevation of the tentorium, well, to do that, you really, have we got my pictures in the way here? Really in this view, I'm just looking at this view. So if we're looking at the tentorium to try and see that, it's really quite difficult to see that tentorium region. It's going to be sitting in here. I think those sort of features are second trimester for a second trimester diagnosis. Yep. Yep. To see that sort of thing. I don't think we'd see that in the first trimester. And I haven't actually seen that reported.
Thank you, Anne. Next question is from Amanda. Do you use a different chart for the BPD outer to outer measurement at the choroid interhemispheric fissure plane and the head circumference in the first trimester to the BPD transthalamic plane in the second trimester? I guess probably the questions is, around the charts, which charts?
Of their charts. Look,
Yeah.
that paper has only just come out and they have information, they have their formula in there. So I guess, I mean, look, you worked, I think, as an application specialist. Is that what you do? Do you put the formula into the ultrasound machine and that can give you that information, or you actually have to put the charts in?
Yeah, you can. You put the charts in. You can download the charts associated with it, is my understanding, Anne. Yeah.
Yeah. Okay. Well, I don't know that they've actually published the charts because they've only just published this paper. I mean, I'm only talking in the last month it got published, and I don't know that information is out there and readily available for us to use as yet, and it definitely hasn't been downloaded into the ultrasound machines. I'd have to have another look at the paper, whether I'm just trying to think. I could bring the paper up. I have it on my computer, but whether you'd be able to, I don't even know that they presented percentiles in that paper either. So I don't know that is there for use. But, previously nobody had described where to measure the BPD in the first trimester. And this work that they've just published is showing us that this position is reproducible. It aligns well with the crown rump length, and it doesn't increase the number of post-dates pregnancies that are born, and you can use it as an alternative. I think once they publish those charts, we'll be able to use it as an alternative or in conjunction with the crown rump length for first trimester dating. But it is from outer to, they did measure it from outer to outer. I've always measured it from outer to inner. I guess if we're going to compare, let's like the BPD plane that we use now, I think people have to measure it in the same way. So it might be, now they've done that large retrospective study, that we can embrace that measurement and that plane across the world. I hope that answers it. And the head circumference, I would measure at that same level as well.
Mm-hmm. Thank you, Anne. Next question is from Lily. Where is the posterior position of the maxilla line, please?
Well, it just runs along. It just runs along the maxilla. So here, see it here? So we just run it along where you can see it. So just there, just on the line. They don't describe it terribly well. None of these things get described terribly well, but you just sit it on the maxilla that you can see in the first trimester. And then you just run it so that it goes through the occipital bone. And then you just look at the level. They talk about that junction, but really it's looking at whether the diencephalon or the thalami is being pulled down towards that sort of line there. Yeah.
Next question is from Lindy. How many types of trisomy are there to be looked for in the first trimester fetal brain?
Trisomy. Well, you can't make a diagnosis of trisomy on ultrasound. You can look for ultrasound features of trisomy. I mean, really, Trisomy 18, spina bifida has been reported in occasional cases of trisomy 18, and for trisomy 13, holoprosencephaly. Apart from that, the fetal brain with trisomy 21 can look normal. I mean, obviously, in that sagittal plane, we're looking for absence of the nasal bone and we're looking for an increased nuchal translucency. But we're not looking, I guess, at the fetal brain to make a diagnosis of trisomy. We're just looking to see whether we think that brain looks normal or not. And I think if you find that it doesn't look normal, then you look carefully through the rest of the fetus to see if there are any other features of chromosome abnormalities that might be present.
Lovely. We've got lots of questions.
Gee.
I'll just do a few
Okay.
more, just a couple more, and then we might call call an end. So next question from Thobakili. At what gestational age is the best to assess the first trimester brain anomaly?
Look, we've started trying to scan all our first trimester fetal brains at 13 weeks and 13 and a half weeks. And that's because we can get maximum information from the fetus. So we can get a really clear anomaly scan of almost the entire fetus. We can see the heart well, you see the brain well. We're doing preeclampsia screening, so we're doing the uterine arteries. So we're getting a lot. You can see the face a lot more clearly. So we're getting a lot more information. So we're tending towards that slightly later time, especially because a lot of our pregnant women are getting the non-invasive prenatal testing anyway. So they've already got an answer to that. So we're looking more for early anatomy. I hope that answered that question. I mean, look, Simon Ma he puts up case studies of diagnosing, brain anomalies and things like that at 9 and 10, 8, 9 and 10 and 11 weeks. I think a lot of those really early ones, like if you're going to start diagnosing things at 8 and 9 weeks, they're probably going to miscarry anyway, because they're usually quite abnormal if you can see them. But yeah, we're trending towards that slightly later gestation.
And just flowing on from that, and we have another question. This is from Catherine. How often do you review the fetal brain earlier than 20 weeks if the 12-week view was not satisfactory?
It depends. If you really can't see it well, we'd offer the person a transvaginal scan. If that's not an option or they decline, if we're bringing them back for an early anatomy scan, they're brought back at around 15 to 16 weeks. Yeah. If we thought the brain was, we had a really high suspicion that the brain was abnormal, we would probably bring that person back about a week later. Yeah.
Okay, that's great. And we might call it to an end there with the questions.
Thank you.
Again, really big thank you to you, and thank you to everyone for joining this evening as well. Really, really great turnout. We do have a post-presentation survey as well, which I'll just launch there now. And if you do have time, it would be great if you were able to answer those questions for us. Just helps us understand whether or what sort of impact the presentation is having for the audience. So please, if you do have time, please fill that out for us. That would be much appreciated. All of our webinars, including this one, was recorded and is available for free on the Radiology Across Borders website. There are topics, there's actually